I do believe there is a significant problem in the early diagnosis of psoriatic joint disease, because the vast majority of patients with psoriasis will take up to 10 to 15 years to develop joint disease after their skin disease has begun. So I always say in 99% of cases those patients will be under the care of a dermatologist when they get their early joint disease. And therefore I think it's absolutely essential that dermatologists spend an extra minute or two with their patients at each visit with their psoriasis patient to determine whether their patients have early joint disease. And it's not difficult. There's questions to be asked like, do you have early morning joint stiffness in any of your small joints, hands and feet, your big joints, your hips, your shoulders, your knees, your elbows, and does it then disappear within 30 minutes to an hour and a half, which is a very classic early sign of psoriatic joint disease. Then during the evaluation of the skin, I then spend an extra minute and 20 seconds, it takes me exactly that long, to evaluate. I take the shoes off patients, I check the fingers and I check the toes for what we call enthesitis, which is sausage fingers or sausage toes. I palpate them, my rheumatology friends have taught me how to do that. I palpate them, the base of the thumb is common, the MCP joints are common, and the IP, distal IP or proximal IP joints. And tenderness in those joints or swelling of those joints is classic enthesitis, which is an early sign in the majority of cases of psoriatic arthritis. The second thing I will look for is then when I take the shoes off, I get them to turn the other way round and I lean down and I rub my thumb and index finger down the Achilles tendon from the base of the calf down to the heel, and then I press on the heel bone, the talus bone, and see if there's any swelling, tenderness or pain in one Achilles versus the other Achilles. And then while they're standing the other way, I'll take my two thumbs and I'll rub it against the sacroiliac joints. Very easy, it takes you 5 seconds to do that. See if there's any pain in the sacroiliac joints. And the final thing I'll then do is I'll get them to lift their heels up and I press my thumb or fingers on the heel and see if there's any tenderness in the heel, because plantar fasciitis is a common early sign of psoriatic joint disease. And many times it is not diagnosed as psoriatic arthritis, and patients go to podiatrists and have steroid injections into the heel, because the Achilles tendon, when it attaches to the heel bone, then goes forward underneath the foot to the plantar fascia. So plantar fasciitis, enthesitis, dactylitis are common early signs that I believe us dermatologists can, because we're very practical and we're very visual people, can diagnose early and then decide on whether they should treat or whether rheumatologists should treat the joint disease. One of the big unknown features, which I think we now have an answer to, is what percentage of psoriasis patients with early joint disease, if left untreated, will go on to permanent joint destruction, which we cannot allow if we diagnose it early. And the answer, and I've discussed this with rheumatologists around the world, is about 50 to 55% of patients, if left untreated, go on to permanent joint destruction. And you can see patients with arthritis mutilans where their hands are totally mutilated because of a lack of early diagnosis. Because once they're mutilated, you can't regrow the bone. So it's vitally important for us to prevent any permanent joint disease by picking up early, and there's no clinical test that can show, if left untreated with a TNF-alpha drug or an IL-17/23 drug, if left untreated, how they're going to develop joint disease. Because our job as dermatologists to diagnose it early. If I have a patient who I've been treating for some time and they've been treated either with topicals, phototherapy, systemic therapy, and they get joint disease, if they have significant joint disease and they have moderate skin disease, in other words, not up to 10% skin disease, then I will refer them to the rheumatologist. Okay? If, on the other hand, they have moderate to severe psoriasis, over 10% of their body surface area, and I definitively diagnose joint disease, which is not too difficult, then I will start them either on TNF-alpha or on either one of the two IL-17 drugs.